Thank you.
Great. We ended a few minutes early, so why don't we take a few questions now, because there's going to be a lot of discussion later. So can the moderators, Dr. Menon and Dr. Chung, please read some questions?
Yeah, actually, we have a very keen discussion on one of the paper is in diabetic cholangiocarcinoma, and which shows that laparoscopic liver resections, particularly the major liver result in the poorer survival outcomes, even with lymph dissections. So we are discussing on the chat room before, right? Why do we think there will be poorer outcome in diabetic cholangiocarcinoma? So using the laparoscopic approach, that is quite contradictory to all other cancers we have been observing, right? So, Chris, any comment on these questions?
No, so I think, in terms of the presentations that have gone through, there was one question that came up, and this is to Dr. Kipriani. The paper was very nice, and the question you have is, how do you see the robotic approach in relation to laparoscopy developing in the future? So if your data is suggesting that the robotic approach has got, the advantages that you mentioned, where do you see laparoscopy sitting in that scenario? Because clearly, one of the things that robotic surgery does do is allows people to go past the learning curve quickly, particularly those who are not laparoscopic surgeons, naturally gifted laparoscopic surgeons.
Well, thank you for the question. That's a very important point. I think that exploring more and more the role and the advantages from the technical point of view of robotics, it becomes even more clear and clear that robotic has a big space in the future of minimal invasiveness. Actually, the point I think is still the topic of the cost effectiveness from the financial point of view, that in the present, I think that influences a lot the application of robotics and justifies its application as well as laparoscopic minimal invasive technique only for cases which are more difficult, as we have explained and partly demonstrated in our paper. I think that the future, when these financial discrepancies will be probably overcome, robotic approach will have a very wide space in the panorama of minimal invasive approaches, and probably laparoscopy will be partly replaced. So I hope that given the advantages, we will go in this direction.
Okay, Umit, you're here. Would you like to comment? Okay.
Yeah. Yes, can you hear me?
Okay.
Yep, we can hear you.
Yes. Yeah, I think some of the results of our work were a little surprising when we looked at everything, but kind of when we do the subgroup analysis and look at larger tumors, larger resections, we kind of come to the conclusion that it may be best reserved nationally to have a minimally invasive approach for ICC be used at bigger centers for those larger tumors. I think as laparoscopic surgeons and future, hopefully, laparoscopic surgeon at for HPV cancer, we want to keep pushing the boundaries of how to use robotic surgery, laparoscopic surgery for all types of malignancies, for expanding criteria. But it's also important to kind of realize the current limitations also when you kind of consider national practice patterns versus kind of the most experienced centers. So it's good to have everything kind of with a grain of salt and appropriately select patients with appropriately selected institutions for such minimally invasive approaches.
So you mean the centers are doing poor outcome, those with high volume who try to push the envelope, or it was done by a center with lower volume with a poorer outcome?
To a degree, I don't think there's necessarily worse outcomes at higher volume centers. I think that's where they should reserve minimally invasive approach for. But again, we looked at the NCDB, which kind of covers 70% of cancer commission accredited institutions across the country. So it's going to represent the US at large, as opposed to the highest volume, most experienced centers. So I think nationally is where most of the reservations with minimally invasive surgery has to be kind of considered, but with better referrals to those larger centers for the larger tumors and for maybe minimally invasive approach as a whole. So hopefully over time, with dissemination of laparoscopic experience training programs, you know, more cases maybe from smaller resections of the liver with robotic, and as surgeons get experience, you know, across the country, we'll hopefully see minimally invasive surgery be used for ICC more appropriately.
Okay. Can I make a
Thank you, Amit.
comment?
Yuka, you want to make a point?
It's me. Can I make a comment?
We can hear you.
Yes.
Yeah.
Well, in open surgery, there are papers mainly from Team Pollock group showing that survival in intrahepatic cholangiocarcinoma is related to the an effective lymphadenectomy. So it might be that the poor outcome is not related to the size of the tumor, but just to an ineffective lymphadenectomy. So basically, the result of an inadequate lymphadenectomy by laparoscopy can be the same reason of the poor survival of the patients.
But do we have the data, or preoperatively, do we know this is ICC, or it is just found by pathology? Because if you don't know this is ICC before operation, you will not do the lymphadenopathy. So if you are doing by laparoscopic, if you know this is ICC, you will do lymphadenectomy. But if you don't know, you probably will not do lymphadenectomy at the surgery. So do we have the data on how many patients are actually known to have this diagnosis before the surgery? Dr. Omid, do you have the data on that?
I do not have that data, but according to the other comments, I think that the lymph node yield is very important for ICC. There's studies out there that say that 30 to 40% of ICC have positive lymph nodes, and the lymph node yield is a very important prognosticator for survival and also treatment allocation postoperatively for these cancers. But in our data, the lymph node yield, although better in open, both open and laparoscopic approaches don't meet NCCN guidelines and benchmarks for ICC. So that can only be a part of the survival difference seen for lap versus open in our data specifically. Even across these 230 patients, the 115 laparoscopic and 115 open, out of all the lymph node acquired, only one patient was positive, which is much less than what you'd expect. So there's a combination of elements that lead to this survival difference. And I think lymphadenectomy is a part of it. And hopefully with time and experience, laparoscopic lymphadenectomy will catch up to open and hopefully surpass it and improve outcomes overall.
This has been an excellent discussion, but we need to move to the break now. So there'll be a 5-minute break and continue the discussion in the chat. And then please come back, visit the industry booths now during the break, and then come back at 10:50 because we have exciting announcements from the awards committee. We have prizes for the top 3 ranking videos and top 3 ranking oral abstract papers. So those awards with their cash prizes will be announced in 5 minutes at 10:50, and then the next session at 11 a.m. So we'll see you back in 5 minutes.
Thank you, David.
Thank you.
Thank you, everyone.